and teaching. So next up, are the slides okay for now? Okay. Is Dr. Ayana Jordan, who is an endowed Barbara Wilson Associate Professor in the Department of Psychiatry. She's an addiction psychiatrist and Associate Professor for Population Health at New York University, NYU, the Grossman School of Medicine. The rest of her bio is in the booklet. And she'll talk a little bit with us today about culturally informed addiction research.
Yeah, thank you. Hello, good afternoon, good afternoon. I am so excited to be here. Lovely people, Black people, African people, those of the African diaspora, and everybody that loves Black people, welcome. I am going to do my best to stay within my 25 minutes, and I will be clear to do that. But I just ask that we all maybe just get up for a second and let's just move our bodies for a little bit, because we've all been sitting. Get up. It's part of my time. I've already started my timer. Just move your body just a little bit and shake it out, because we have a little ways to go. And I do want you all to remember what I said this afternoon. So please take a seat. I'm going to, okay. Wonderful. So this is me. I just love this picture, y'all, so I had to show it. But I am going to veer a little bit. I was going to do lessons learned, but I want to talk about this amazing research program that we're doing in Connecticut and New York. I was at Yale for 11 years, and I just recently moved to New York City. And so I want to talk about Imani Breakthrough. For all of you all who speak Swahili, you know Imani means faith. And it really is a program for Black people who use drugs that was started by Black people who use drugs. And we just talk about collaborated with them to get the program going, and thinking about how we can create research programs that are more culturally informed for Black folks. So, going the wrong way. So I always start my talks, obviously, thank you, Professor, who started out with acknowledging the indigenous people, and I want to do that here. For me, as a Black woman who lives predominantly in white spaces and feels like that's very oppressive, it's important for me to always really pay heed to the Black Lives Matter movement, because that has really catapulted my career. I've been doing health equity research for a long time, but it really didn't start to get funded, and the importance of it wasn't really underscored in the United States until it was the public assassination of George Floyd, what I call state-sanctioned violence. And so the Black Lives Matter movement started with Trayvon Martin being killed. It was a young Black boy with a hoodie walking to get some candy in the store, and he was killed. And that wasn't enough. It took many people being killed by the police, and like I said, most publicly George Floyd, to get us to this point. And so I say his life will not be in vain. And thinking about how I can catapult those who use drugs who are Black, those who are really oppressed because of just who they are, and thinking about how can we partner with communities to bring about our own solutions. Because I don't think anybody's going to save us but us. Okay. All right, so what do I want you guys to take from today? My objectives are threefold. The first thing I want you to take away is understand the constructs and social conditions that have contributed to the disproportionate rate of Black people in the United States. It's not happenstance. It's not because of the color of their skin that they're dying, but there are actual constructs that exist in the country that have led to Black death. The second objective is I want you to understand the individual and structural phenomena that actually contribute to why Black people with substance use disorders are actually not going to treatment. It's not like they don't want to get help, but there are actual things that are in the environment, right, that exist that contribute to decreased treatment initiation. And then finally, I'll talk about the Imani Breakthrough Program, but I gotta go back so you understand the context of why Imani is so, I think, transformative and innovative. Okay, we are in a liberated space, y'all. What is it? AGI. MHI, AG-MHI. We are in a liberated space. I'm gonna get it. I said, Dr. Durham, how come you didn't tell me about this? I love this conference. I will be a part of it in the breakaway groups. And I love the you. You had the you. Your picture is up here. Maybe I'll be you, but I don't know. Anyway, we're in a liberated space together, so that means that you don't have to agree with everything that I say. I genuinely don't care. And I ask that you ask questions that may be uncomfortable. I realize that I think the myth of safe space, not everybody is safe physically or psychologically. So I ask that we be in a liberated space together and we have some time to discuss how did this come about, how do you want to advance research, what are the things we need to do so that people in the diaspora can be well. We're in a liberated space together for the next, 15 minutes or so that I have left. Okay, so what is the current state of affairs and why is Imani breakthrough so important? Black people have worsening substance use outcomes than any other racial and ethnic group in the United States. Again, it's not because of any fault of their own, it's because of the system of racism. This has been exacerbated during the COVID-19 pandemic. And I think what is upsetting to me is that in the context of these worsening substance use outcomes, it continues to be overlooked by regulatory agencies like healthcare, like academia, like public policy, law enforcement, etc. And what does that look like? That relates to continuous rigid methadone policies. So in the United States, you can only get your medication for opioid use disorder, a medication called methadone, through what's called OTP programs or methadone clinics. You have to come every single day. You only get one day off. That's ridiculous. Why would we want somebody to come every single day in the middle of a pandemic to get their medication? You can't even qualify for 2 weeks of medication unless you've been in treatment for a year. You cannot qualify for a month of medication unless you've been in treatment for 2 years. They check your urine every single day. They make you open up your mouth to do a mouth check. They treat you like criminals. How can we say that we want people to be well if this is how we're treating them? During the COVID-19 pandemic at the beginning, there was an exemption so that they said, okay, we'll give you 14 or 28 days of your medication. How many people who were black that actually got their methadones in predominantly black cities actually got 14 or 28 days? Right? So that's the research that we're doing. Also, there's decreased MAT initiation. MAT stands for medication for addiction treatment, so like a medication like buprenorphine. People say, okay, well, buprenorphine you can get in office-based clinics, but even the data has shown us, and this is the JAMA letter that was published in 2019, even when you have access to insurance, black people are less likely to be prescribed this medication. Not that they don't have the diagnosis, but they're not getting it. So these are the systems that are in place that are not allowing black people to be well. And then there's a lack of culturally informed treatment. So why does the treatment always have to focus on kind of Western European values, especially if people don't identify in those ways of treatment of modalities? And finally, there's a decreased lack of funding for black researchers. So it's not that we're not here, it's not that we don't have the publications or haven't gone to the best schools, but we're still less likely, and you don't have to believe my word, this is all in the literature, to be funded. So these are all reasons that contribute to some of the ongoing disparities. Okay, I just love to put up this slide because there's so much focus, and I don't know how it's been within the diaspora, but at home in the States, on the opioid crisis, mainly on white people. But last year alone, the highest rate, and I don't have a pointer. Oh, I do have a pointer. Okay, y'all. Yeah. So that 2021, per 100,000 people, the highest rate of drug overdose deaths were amongst black people and indigenous people. When I ask my colleagues that, they have no idea. They think it's black and white, or white and Latinx. And the bottom line is that the narratives, the media, the ways in which we talk about drug overdoses, it totally eliminates entire populations. So our research is necessary, not just because to do research for research's sake, but it does drive the public narrative of who's being affected. Okay. Oh, am I going the right way? This is So I wanted to bring about this concept of othering into the milieu. Is not just being left out of conversation because of your race, and that's what's happening with black people with substance use disorders, but also because of the identity of having an addiction, right? So we have to think about multiple intersecting identities. Having mental illness, having addiction, being Black, all affects what type of research is done, what are the research priorities, who gets the funding, who doesn't. So being able to have these policy papers, being able to put out our research is important because that drives data and also funding opportunities. So it's important with these working groups. I know we're all tired. I'm tired too, y'all, but the work is necessary in order for us to take care of our patients. I always say that apartheid, racism, the legacies of that continue to shape what is happening. If you take nothing away from my talk today, you'll know that it is because of the system based on race or racism. That's why we're having health inequities. It has nothing to do with the individualized person itself, right? So I don't want us to blame the victim or blame Black people in my case of why we are having worsening overdose rates. It's because of these systems based on race that structurally advantage white people over Black people. And what does that look like? That looks like differential access to goods and services in housing, education, employment, on a personally mediated racism level, thinking about how there is assumptions about the abilities or motives based on others of how they look. So we know that if a Black person goes into a clinic to get care, even if the doctor is Black, regardless of what color the doctor is, they're less likely to spend as much time with that patient as they are a white patient. A Black patient is less likely to have the risks, benefits, and the side effects of that medication discussed with them. So we all have to be thoughtful about how we're participating in this system of racism. And then finally, I think it was Professor Jimmy who was talking about this, is that kind of the acceptance of these negative messages by those who are being oppressed about themselves. So I think this is the most tragic, is the acceptance of the stigmatized races of their own abilities or intrinsic worth. So we can't think about access to addiction treatment if we don't think about how these perceptions are really affecting, if people want to engage in recovery, because for what? If you think that you're not worth it anyway. So how can we develop, right? How do people see themselves in order to be able to recover? And we talk about this in Imani, which is really important because representation is key. I say that I'm always going to go over the racist war on drugs because that legacy really has dictated how we think about addiction care for Black people in the States. This green line is just the number of overdose deaths. I want you all to see that all this money, and this is billions of dollars that have been spent in the United States to counteract drugs. It's not working, right? The line keeps going up. Okay, so that's the take-home point. The line keeps going up. And also, if you look at the different substances, so heroin, cocaine, opioids, and now we're dealing with multiple substances at one time, all the laws that have been created to really counter or address these drugs have not worked in terms of stopping people from dying. And then one of the laws that I just want to bring your attention to is the 1986 Anti-Drug Abuse Act, and that was really introduced by Ronald Reagan, who was one of our presidents. And he said, he kind of doubled down from when Richard Nixon was like, you know, I'm going to criminalize Black people heavily. They are ruining our neighborhoods because of their drug use. They need to be thrown behind jail. And that led to an overrepresentation of Black men specifically in the jail system. They didn't have the luxury of getting treatment for their opioid use disorder like white people do. A lot of them still remain in jail to this day. But Reagan doubled down on Nixon's policies and said, if you have 1 gram of cocaine, crack cocaine, compared to 100 grams of powder cocaine, you still get the same mandatory sentence. Why did he heavily criminalize crack cocaine versus powder cocaine? Because that was the type of substance that was more likely to be in Black and poor neighborhoods. So that led to, just this Anti-Drug Abuse Act led to an entire 60 to 70% of the criminal population being Black, even though they make up the minority of the population. And then they tried to introduce the Fair Sentencing Act to correct that disparity, but it didn't work. It lessened it, but it didn't work. Why am I spending my talk on research to go over this? Because it affects how people live. So when someone has a criminal record as opposed to being treated medically for their substance use, it leads to difficulty finding employment. If you're not employed, how are you going to get housing? If you are able to find housing, it affects where you're able to get food, transportation, your ability to participate civically, on and on and on. And if we think about Maslow's hierarchy of needs, right? Being able to meet your physiological needs, your safety needs, love, esteem, self-actualization, being involved in the criminal legal system impacts all of that. So when we are thinking about developing research programs that actually help Black people with substance use disorders, we have to take into account all the ways they have been negatively impacted in this way because of the laws that are legal in the land, right? So we can't just think about narrowly focused about the disease itself. We have to think about the context. So that's why I spent my first, how many minutes do I have now? 10 minutes talking about that. I got 10 minutes, y'all, and I'm going to wrap up on time because Dr. Jones said I have to. So I'm going to move on to the type of research that the Jordan Wellness Collaborative does. That's the name of my research lab. We do, it's called CBPR, Community-Based Participatory Research. That's a mouthful to just say that it's a partnership approach that equitably involves community members, key stakeholders, in this case, Black people who use drugs, researchers, and all others like loved ones, imams, religious figures, whoever, into the research process, because we know that all of these people are negatively affected by substance use. So it can't just be me as an academician in the white ivory tower. Why is that tower white, y'all see? But it can't just be one person, right, thinking about what are the research questions when it affects everyone. So really moving around in JWC, we don't want to do research on communities. We don't even want to do research in communities, but we want to partner and do research with communities to understand what are the most pressing questions. I may want to focus on the overdose rates that are driving or going much higher because of fentanyl. And the community, I say, Dr. Jordan, wait, hold up. We got to focus on getting food because people are not coming to your trial if they can't eat. So those are the things that I'm saying. What are the priorities and how do you partner with the community in order to drive those priorities? The goals of the, I'm just so happy y'all. I just want to just put Jordan Wellness Collaborative up there again because I worked hard to get to where I'm going. Okay, so what are the goals of JWC, the Jordan Wellness Collaborative? Is one, to foster mechanisms to enhance community involvement in mental health research, making sure that all of the data, all of the papers, like, yes, I published in Lancet, but nobody from the hood cares about Lancet. So how am I getting those research findings, data, communicated in the way? So using social media to do that, using local newspapers, being on the radio, so that's like, okay, come to this meeting, we're gonna have food, sometimes we have drink, not because I'm trying to push people to use substances, but I want them to show up, to talk about the findings, okay? I'm keeping it real, y'all can take me on that. Also, the second thing is that we want to provide treatment in non-traditional settings because we know not everybody is comfortable going to hospital settings. So we provide treatment in like churches, synagogues, places of religious kind of liberation where people feel that they can be safe. Okay. All right, so now I'm going to move into Imani, talking about the why. I love this poem. I'm just going to read the top part. It's from a woman who is living with HIV and also has a substance use disorder, who's Black. She said, we need you, our brothers, our sisters, our people. Help us reaffirm ourselves and loving ourselves. Hold us when we can't stand, because soles of shoes have traveled on our backs for so long. We need you, our brothers, our sisters, our people. So that is the spirit of Imani Breakthrough. It's a research project that has been funded through the National Institutes of Health. We're so excited to have the funding to do this work, but I call it, even though it's a research program, I call it a project because that's more culturally acceptable to the participants. I just want to shout out to my multiple principal investigator, my partner in crime that does this work. Her name is Dr. Sherelle Bellamy. I have her picture up here because she identifies as a person living in recovery from mental illness. She's also in recovery from cocaine use disorder, and she's a professor at Yale. Give it up for her, Dr. Bellamy! And it's important for me to, and it's not that I'm not putting her business out on the street, she has shared this. It's important for me to show because I want people to see what it looks like to be in recovery. Not all the negative images that we see on TV or just the people who are praised or whatever on the street. People in recovery can do well, so that's important for the people that are in the study. Okay, so what do we do in Imani Breakthrough? Well, we promote health and healing by creating a sense of unity. Who are we? Creating a sense of collective responsibility that I can't be well if somebody in my community is not well, and we do that through a participatory process. You see, I didn't say anything about substance use. I didn't say anything about decreasing substance use because this is the values that we go by. If we're able to do all that, health will come. Decreasing substance use will come, but that is not the primary driver. Okay. So, what is the actual program that we are using to bring people into the faith-based settings to get care? It's called Imani Breakthrough. It's based on an evidence-based project that was developed at Yale called the Citizens Program. And what we found is that people for serious mental illness, if they went through this set of classes for 12 weeks, they also had decreased substance use. This is without using any medication or anything. Just by going to these programs or sessions, 1 hour per week for 12 weeks, they were able to reduce their substance use. It's called the Citizens Project. You can Google it. There's papers about it. So we integrated this into dealing with the social determinants of health, or what SAMHSA calls the 8 dimensions of wellness: spiritual, emotional, physical, financial, environmental, social, intellectual, occupational dimensions of health that are necessary in order to be well. So for instance, when people come into the church, research participants, they have to identify what part of these dimensions do they need help in, and once they figure out what goals they want to meet, then in that second part, in that next 12 weeks, I assign them to a peer recovery coach, somebody that has still uses drugs or somebody in recovery from drugs, to say, you know, this person has identified needing help in, I don't know, finding housing. So they're going through the classes during those 12 weeks. They're learning about what it is to be a citizen in the community, but in the next 12 weeks, that peer facilitator is helping them just to find housing, okay? And then when they get done with the entire 6 months, because it's a 6-month curriculum, then they have a huge graduation. We invite people from the community because that might be the first time in their identity as somebody that uses substances, are they actually affirmed for their humanity. Like, we don't consider you an addict. We think that you are someone that has value, that has worth, and we want you to participate in the community. We've reached over 1,000 people. And so what we're showing is that just through this component, which is how we got funding from the NIH project, that we've been able to not only help people reduce their substance use, but decrease drug overdose deaths. So that's powerful. Okay, so now what are we doing for the actual study? The treatment we're proposing is this, and we started, guys. That's why I said I gotta change. I gotta tell the people about the project. We just started last month. So in the first month, everybody comes in. The inclusion criteria, you have to identify as Black or Latinx. You have to be over 18. You have to meet criteria for a substance use disorder. You come in, everybody participates in that Imani program that I just went over. And then at week 4, during that Imani program, we talk to you about medication for addiction treatment, what that means, all that. And then at week 4, if you say, okay, Dr. Jordan, I'm interested in medication for addiction treatment, you're either randomized using a program to medication for addiction treatment, so actually getting medication in the church setting, or randomized to getting addiction treatment in the community. And so we're going to see at the end of this project or this program which group does better. People who are getting medication in the church via addiction psychiatrists who look like them, and they provide the medication via telehealth, or people who get randomized to medication treatment in the community. We think that we're going to do better in the church. We have to see, that's why we're doing the study, it's ongoing. But also, what I want you guys to understand is that nobody ever gets kicked out of the study, right? So even if that week 4 they say, you know what, I'm good, I don't want to do any medication, they still stay in Imani because we have the pilot data to show that even if you stay in Imani with nothing, you decrease your substance use. So that is valuable because we listen to what people said. Not everybody wants to take medication. Not because it might not help them, but because that's not how they might want to enter into recovery. Or they might not trust you because Black bodies have been exploited for so long in the United States, and there's a history of that. So whatever the reason is, we just want people to know, we're glad you're here, and we're going to respect your decision. Okay, so nobody gets kicked out. Another thing that we're studying with this research program is that we're going to see, does choice affect overall outcome? So those who had the choice to go and get medication or not, did that have a positive impact on their outcome at the end of the study? We'll see. Those who chose to stay in the church, stay in the project and not get medication, did that influence their outcome? So these are the things that we're looking at and we're excited about it. I'm almost done. I'm psyched. I'm on time. Okay, don't say nothing. I'm finishing up. So this is really innovative because, like I said, we have a strong focus on community-based participatory research, trust. It's community driven. We focus on harm reduction. That's another thing, so that people don't have to want to stop their substance use. We just want to optimize safety and minimize harm related to their substance use. We give them things like naloxone, which is the medicine to actually reverse accidental overdose. So these are all things that happen. They get fed when they come to the program, all of these things. And people with lived experience are paid to be a part of executing the project, so we're happy about that. I'm going to skip next steps because we can talk about it, but I just wanted to thank all of the pastors in the churches that I work with. We're in 8 different churches at home, the facilitators, the people with lived experience who actually do the work. Thank God I'm at a point where I don't have to do the work anymore, but I also just want to say that I am driven by all the people who unnecessarily lost their lives to drug overdoses. This is what fuels me. This is what leads me to do this work. And all of those that are part of my team, both at Yale and at NYU. And then I say I'm a quintessential auntie. I'm a fur mama. Those who follow me on social media, you know that I love my fur babies. So those are my children, y'all. And I'm an auntie. That's the most important. So Lulu Bear, I wanted her to go to a historically Black college and university, but she's at Harvard. Oh well, but she's a student. And then these are my nieces and my nephews, and then my god baby Ayana, who lives in Sierra Leone. Thank you for your time and attention.
Thank you very much, Dr. Jordan. So we're going to move on to the next speaker because of time, and I think we'll have questions just now at the end of that. Dr. Mviso Taratana is next.